situation, the damage of endothelial cells in presence of other risk factors we will discuss, start a damage of the microvascular structure, in particular endothelial cells. And when we observe the damage of endothelial cells, already without systemic clinical symptoms, start a local immune inflammatory reaction. And here starts possibly the autoimmune response. We can at this time discover some specific autoantibody. And as the disease progresses, the microvascular damage involves all the area of the body, and there is a fibrotic reaction, and this fibrotic reaction is progressive and becomes systemic, and here we have systemic sclerosis, progressive. The last part, due to the strong fibrosis, is the sufferance of the tissue with tissue hypoxia, ischemia, and organ insufficiency. Maybe the kidney, maybe the lung, maybe the skin with ulcers, and so on. So if we consider this progression and we look what we can observe in correlation with the clinical symptoms, we observe that there are some risk factors that involve genetic, environmental factors, epigenetic mechanisms, hormonal problems, and in a very early microvascular damage, we can already observe, as we will discuss, signals of abnormality in the structures of the microvessel, of the capillaries, with dilation, as you can see here. As the damage progresses, the dilated capillaries lose red blood cells, and you see these initial microhemorrhages that are a signal of sufferance of the vessels. Microhemorrhages, together with dilation, are important markers. That is not anymore a primary benign renal phenomenon, but is something more with involvement of the immune system. And at that time, serum autoantibodies are detectable, specific autoantibodies. And it's classical the presence of giant. We will discuss giant capillaries, 5, 2, 3, 4, 10 times larger than normal capillaries. Here you see a normal capillary, and here you see a giant capillary with edema. This is a loss of fluid, serum, because the wall of the capillaries is damaged, and capillary leaves and start to do microhemorrhages. And the quantity of microhemorrhages increase. Some capillary die, so start the desertification of the area. This yellow color is due to the fibrosis. And you can see how the number of capillaries in 1 millimeter is decreased. You can count 6, 7, 8 capillaries compared to the 12 capillary in almost normal conditions. And you can see here as the progress goes, the angiogenesis. A lot of fibrosis, loss of the normal array, and angiogenesis. New capillaries, they are not able to restore the normal structure you have in normal conditions. So as you can see, you can follow, looking at the morphology and at the number and at the distribution of capillaries, the progression of the disease. In 2000, we proposed patterns for the qualitative analysis of the damage. Now we have a very early pattern we are working on. Anyway, the 3 important patterns in capillaroscopy include the early pattern, the active pattern, the late pattern. In all of these patterns, you will see are associated with different clinical implication of the disease, with the progression and severity in such direction. So if we look at our capillary that has been damaged, the endothelium damaged by Raynaud, by other conditions, The damage of the cells include the activation of cells, white blood cells that flow in the capillaries, and migration of these cells, production of growth factors, cytokines, and even we will discuss this important aspect, the endothelial to mesenchymal cell transition. In few words, when the capillary is going to die, the endothelial cells don't die, but are transformed in myofibroblasts, fibroblasts finally, and produce connective tissue disease, including collagen, and this is the fibrosis. So the area of the capillary that die is substituted by fibrotic tissue. And this means clearly the suffering of the organ, the suffering of the tissue, because less oxygen, less life for the organ, and insufficiency due to the fibrotic tissue that substitute. So the microvasculopathy is the first step in the progression. And with the capillaroscopy, we can detect exactly the beginning of the process before the patient is affected by the final fibrotic disease or loss of capillaries. So in other words, the microvascular damage is the earliest signal, morphological signal with this small camera or microscope you can detect without any invasion of the tissue or damage. Is just light. So I told you that in normal condition we have, as you can see here, the capillaries are well organized, as you can see. This is subvenous plexus, and you see each capillary is almost similar to the other one. There are some tortuosity, there are some crossing, but these are non-specific abnormality, are not related to any pathological condition. And so this is the normal nine-fold capillaroscopy that offer to you, for example, a patient or a subject with primary Raynaud phenomenon, not associated with any organic microvascular tissue disease. But as I mentioned, during the Raynaud phenomenon and in presence of risk factor, genetic, hormonal, and so on, or toxic, the capillary may be altered with some dilation that are along the structure of the capillary, not necessarily all the capillary structure or all the capillaries, maybe just one branch of the capillary dilated. Still the primary Raynaud, you don't have antibodies, but this is a signal that is called very early. This is under publication, and this is very early and need some experience before to detect these early changes. They predict in average period of 6 months the presence of the real giant and early pattern. So at that time, no antibody, and in the very early, you have only dilation, more than 20 micrometers, that is normal capillary, but less than 50 micrometers, that is the classical giant. So it's a sort of transition time between the normal condition and the effects of the microvascular sufferance, an abnormal enlargement, but not yet the giant. This is a very early condition and start in some way the reaction of the tissue, but not yet antibody production. So we look at the quantitative alteration of capillary diameter that have a predictive value for the early capillaroscopic pattern, as I mentioned to you. And here, this average diameter around 13 micrometer, that is more than 20 normal, less than 50 pathological, is a sort of transition from the Raynaud and associated clinical symptoms up to the real early pattern with Raynaud and associated antibody and developing autoimmune disease. So it's important for experts to look at this for centers that use capillaroscopy to see how many abnormal dilation are present over 30, around 30 average, because if you have a more than 40%, this is a very early pattern, and anticipate the classical early pattern with giant capillaries over 50 micrometers. So not anymore 20, not anymore 30 average, but over 50. Even one capillary with a diameter over 50 micrometers means early pattern associated with an autoimmune disease. So here in the early, you have, as usual, the damage on the endothelial cells, the progression of the inflammatory cells along the wall of the capillaries, and the damage due to the expression of the adhesion molecule due to the production of growth factors and cytokines. You have the dilation over 50 micrometers, that is the real giant capillary, the true giant capillary. At the same time, the production of vascular endothelial growth factor that try to restore the damaged capillaries is not sufficient, even because some isoforms are present that are not able in systemic sclerosis to reconstitute the lost capillaries. But together with the loss of serum, you have the loss of red blood cells. So increase the permeability of the giant capillaries, the dilatation, and you get the hemorrhages because the red blood cells leave the capillaries at the apex and form the micro hemorrhages I already showed to you before, together with serum. And so you can have the so-called puffy finger or edema around the cells, around the capillaries. So this is the slow progression. In the early, compared to the normal, you see that you get dilations, homogeneous dilation. This is a true capillaries, giant capillaries that need an homogeneous dilation of the apex, afferent, and efferent branch. This is a true giant capillaries, and you evaluate the diameter at all level. So when these start to be destroyed, leave red blood cells and appear, as I explained, the microhemorrhages. At that time, you have already specific antibodies, specific in systemic sclerosis in this case, because the reaction of the immune system against the cells, altered cells, is started. And if the concentration of specific antibodies is enough to be tested, you observe a signal of immune system activation looking at the serum antibody concentration in the blood, like SCL70, anti-topoisomerase, anti-centromere, and so on. There is a fast algorithm produced by Vanessa Smith and our Euler study group on microcirculation that is very easy to differentiate the scleroderma pattern from non-scleroderma pattern. This is a free article on Autoimmune Review. And we just discussed it in primary Raynaud. You have a non-specific capillary abnormalities, including non-symmetrical dilation and some crossing or other strange structure, but are non-specific. So we cannot call this secondary, but primary still. But in secondary Raynaud, these dilations become symmetric, diffuse with edema. You see this fog, you see the loss of capillaries, and here the symmetrical dilation are specific for autoimmune diseases, in particular systemic sclerosis, dermatomyositis, mixed connective tissue disease when moved to the scleroderma-like condition. So this algorithm is an easy system to discern between the two conditions, and was assessed during the Mueller Cup course that we have done, sorry, this is zero, in Genova, was validated by 100, and the conclusion was that for the first time, a clinical expert-based fast-track decision algorithm has been developed. And if you have, as mentioned, a density over 7, around 9, 10, no giant, this is no scleroderma pattern, you have category 1. If you have reduced the density less than 7, you have a giant capillaries, then you have category 2, and you have the secondary renal phenomenon. So it's clear that the algorithm helps to distinguish between the primary and secondary renal in a very, very important manner, an easy manner. So if we look at the next slide, of course, when the disease, the damage progress, you get another pattern, much more severe, that we can call active pattern. Here the immune response, it's well expressed by B cells, and antibodies become really evident. But it's important also the activation on macrophages in the tissues, because we have a transition from inflammatory macrophage M1 to profibrotic macrophages M2. And profibrotic macrophages produce themselves connective tissue disease, and so produce fibrosis. So still the increased permeability, still the microhemorrhages, still the edema and the microvascular leak, but start the production of extracellular matrix. The active pattern is evolution of the early pattern with much more, as I mentioned, giant capillaries, much more hemorrhages. And what is important is you see the color of the ground is white because the light reflects on the fibrosis. You see some angiogenesis, loss of capillaries. The number is here is a 7, but even under 7 easily if you consider that the window of observation is this one. So the window of observation in the middle of this is 1, 2, 3, 4. When we use the counting system, I will show you. So this is the active scleroderma pattern. And we can reverse with the therapy this pattern. If we use a strong immunosuppressive therapy, if we improve the vasodilation, if we improve the vascularization with dilatory drugs, we can even, at least partially, going back to the less active, less severe desertification. The late pattern that we don't want to see anymore, and fortunately with the new combination therapies with immunosuppression, dilation, antifibrotic therapy, we see less and less patients with late, new patients, they don't progress too late, is characterized by the fibrosis, myofibroblast differentiation and proliferation. Where they arise, the myofibroblast, that means active fibroblasts, capable to synthesize connective tissue protein and to secrete the protein in the tissue, arises from fibroblasts that circulate as fibrocytes in the blood and move where you have a wound, for example. If you have a lesion of the skin, you have a wound in your body from the blood, circulating fibrocyte migrate, become fibroblasts and produce the wound healing, the connective tissue, the scare. But also from pericytes, there are mesenchymal cells around the vessels and are transformed in fibroblasts. Of course, the resident fibroblasts are activated as myofibroblasts in the tissue by the growth factors secreted by platelets and other cells, T lymphocytes, for example. The transition of macrophages from M1 to M2, I told you, become profibrotic, and high production of TGF-beta, transforming growth factor beta, endothelin 1 is a product of macrophages and is an enhancer of such transformation. But also the adipocytes are found to underway this mesenchymal cell transition. So the adipocyte become myofibroblast in the area of the inflammatory, immune inflammatory reaction. And so together with the endothelium that I mentioned before to mesenchymal cell transformation, so the endothelial cell and adipocyte become myofibroblast, you can imagine how the tissue with different rate depend from the single patient and the therapy become progressive fibrotic. And you see patients with such fibrotic disease that become very severe with lung insufficiency, cardiac insufficiency, gastroenteric insufficiency in short time, question of months. The fibrosis is the final result. And so you have the three pattern, classical, already described by our group 20 years ago, early, active, and late. So it's clear that the angiogenesis that characterize the late means insufficiency of oxygen, insufficient of function to the tissue. It is a very severe condition. You can see here on the face of such patients the fibrosis. You see the yellow color of the skin, and the spiders, the angiogenesis. Some giant you can detect sometime, like here, but this is mainly angiogenesis. And you see here the angiogenetic vessels everywhere. Just looking with the face of the patient, you can see also the dermatoscope, but you cannot count here because it's impossible to get a millimeter linear here. Is a square millimeter, you can do that, but capillaroscopy is much better and useful when you look at the navel area. So the progression of reduction of the capillary number reflects the disease activity, and together with the increase of specific antibody led us to join the clinical condition to the immunological conditions of antibodies to the morphology with the different patterns, early, active, and late. It's clear that microangiopathy, microvasculopathy, as I mentioned, is connected with different clinical complication of the disease. The most easy to use as example is systemic sclerosis, where this story is so clear. So you can get, as I mentioned, digital ulcers, pulmonary arterial hypertension or interstitial lung disease before, or scleroderma renal crisis, but also, as we know, involvement of the heart, involvement of the gastroenteric system, and so on, even the peripheral nervous system with fibrotic lesions. So this pilot study showed that the worsening of scleroderma pattern predict future severe organ involvement. So looking at the pattern that is very honest in mirroring the situation of the pathological process and the physiopathology, you can predict the progression of the disease looking at the kind of pattern you have. And for example, for future severe lung involvement, based on this analysis, it was found that there is a clear progression. If you look at the early, or you look at the late, you can see that the association between the baseline pattern and future severe vascular involvement in the next 18 months, in 18 or 24 months, it's detectable and it's absolutely reliable. So lesions are detectable with morphology, clinical progression of the lesions. If we look at this moment, at the timing of transition between the capillary patterns in systemic sclerosis, this is a study produced in 2012. You can see here that if you look and you observe a patient with Raynaud and the early pattern, at that time, that is initial disease, rare or impossible in this casuistic 38 patient to observe pulmonary hypertension, kidney involvement, very rare lung involvement, 6%, gastrointestinal just esophageal involvement in 44%, and digital ulcer. But as already you progress, for example, to the active pattern, you see that increase the gastrointestinal, the lung involvement moved to 67%, the digital ulcer to almost 40%, and interesting, the sclerodactyly even increase with fibrosis of the skin. And in the late, of course, almost the maximum expression of all the organ insufficiency, at least in such casuistic, over 5 years of follow-up shows how is the timing. Follow-up 84 months, that means almost 5 years. In a second study, we look at this ninefold capillaroscopy from a large number of patients. Almost a number of 3,000 patients were analyzed, looking at the different pattern, early, active, and late, and looking at the clinical complication, digital ulcer, pulmonary fibrosis, pulmonary hypertension, muscle sarcopenia, joint contracture, synovitis, and so on, renal crisis, tendon friction, and even conduction block at the level of the heart. And you can see that from the early up to the active, up to the scleroderma late pattern, you see how the percentage of systemic involvement increase, even if the Raynaud is still the same, but the involvement, for example, of the lung moved from 14 to 27%. And so the late scleroderma, unfortunately, is associated with the most severe form of disease. The consequence of vascular abnormality, some of the most evident are the digital ulcers. And as I mentioned, this is due to the loss of capillaries, ischemia, hypoxia, fibrosis, but loss of tissue if some trauma or infection arrives. And here we can say that ninefold capillaroscopy during the day-to-day clinical use in your clinic may be a very, very easy system, getting a prognostic index at least for the progression of digital atrophic lesion. This is sensitivity very high, specificity very high of this. And this is based just looking at the number of capillaries. If you count the capillaries and you look at the decrease of number of capillaries and you look over the time, you see that you can have a prediction for the future digital ulcer or for this more severe progression digital ulcer in a period of 6 to 12 months. just looking at the number of capillaries and decrease of the number of capillaries. You see the number of capillary, how decrease, and this is considered the most important parameter that you can, in the practical activity every day, look at. Not important the number of giant, not important number of microhemorrhages, important the number of capillaries that survive at the progression of the disease and are less and less. So we evaluate with the net of the capillaroscope the number of capillaries in normal, and you see that there is a progressive reduction that may change over the time, of course, regarding the patient, for example, the severity of the patient, but usually less than 7 means, as you saw from the algorithm, plus giant, for sure category 2, so means patient with an associated severe autoimmune disease like systemic sclerosis. In this large study that involved 623 patients from 14 countries and 59 centers in Europe, you can see that we found over 120 different parameters related to the different all possibility that you can observe in capillaroscopy. The most important parameter to predict the digital ulcer was to look at the number of capillaries in the middle finger of the dominant hand. So this is a statistical significant univariate and multivariate analysis, and so the number of capillaries by this study was considered the best predictor of the disease. Number of capillaries with patients with new digital ulcers, and the number, as you can see, average is very low and predict the progression. This is clearly, sorry, I go back for the digital ulcers, current and related to the critical digital ischemia, so the very acute renal phenomenon. We published 2 years ago an automated system to count the capillaries in order to get an application, an app on the capillaroscope that may make easy to compare the data from different centers, because it's an automated software to count the capillary number, the so-called autocapy. And looking at this and looking at the comparison with manual evaluation, the correlation was perfect. So very high correlation is a very sophisticated software published in the journal Microcirculation. And in this manner, the machine count, the application count the number of capillaries with a very complex software. And so using this system that was validated with inter-rater and intra-rater evaluation and was tested, as I mentioned, the reliability was found very high with 4 different observers, considering healthy subject, considering primary renal phenomenon, and considering secondary renal phenomenon, that means in this case sclerosis patients. And you see the inter-rater and intra-rater and inter-rater I can say validation, it's very high. Inter-raters and intra-raters. At this point, we can say that this automated software is important because give us a much more objective system to evaluate the number. What about the lung and how capillaroscopy may also predict the progression of lung involvement? Well, the fibrosis that we observe in the lung, the progressive loss of capillaries and progressive fibrosis, systemic sclerosis, of course, causes pulmonary hypertension. Is one of the causes, of course. And one very important study found a correlation between the number of capillaries and the progression of the pulmonary arterial hypertension in terms of millimeters of mercury. You can see here this significant, very significant correlation. Less capillaries, under 7, more risk and severity of pulmonary hypertension. So once again, the morphology, the fibrosis and the loss of capillary is useful to detect in a very easy way, even if we consider the idiopathic pulmonary hypertension, even in this condition, compared to systemic sclerosis, pulmonary hypertension, and systemic sclerosis without pulmonary hypertension, the number of capillaries is crucial. In healthy subjects, around 10. In idiopathic pulmonary hypertension, 7, 8. And if you move to pulmonary hypertension, systemic sclerosis, around 4. So less than 7 is a condition that is associated with secondary renal phenomena. So in pulmonary arterial hypertension now, a systematic review of the literature concluded that the progressive capillary loss is correlated with the progression, as well as the morphology, the altered morphology. It's another important parameter. And this is important because with very easy, safe, and cheap system, you can really associate the number of capillaries with the presence and the progression, for example, in this case of pulmonary involvement. And this sclerocap study evaluated the presence of and the two methods and evaluated the association within the pattern, early, active, late, and again the scleroderma type and severity. So limited cutaneous systemic sclerosis and diffuse cutaneous, together with clinical parameters of lung insufficiency. And again, was found that there was a strong correlation with the antibodies, of course, and with especially the lung involvement. So the active and late pattern specifically associate with the severity of the disease. And the old classification from Marek, here were compared the Marek active pattern with our late pattern, almost show the same, but unfortunately the active pattern was not so important or predictive, because was already linked to the late pattern as described the morphology of the old active pattern. So the need of a real active pattern between the early and the late here shows how is important, because linked to the progression of the clinical involvement. So we made a 12-year study evaluating the pattern, the capillaroscopic pattern, and the correlation with organ involvement in systemic sclerosis patients. And again, looking at the progression over the years, up to 12 years, you see again a significant correlation, especially with lung and esophagus progression of damage. This is a very important aspect that we must consider, because once again, even over a long follow-up of 12 years, you can really, by morphology, by the pattern and the number of capillaries, predict, looking at the prediction index, predict the progression of the disease. It's clear that patients showing the late pattern after 12 years were much larger, but again, the esophagus and the lung are the most important organ involved. If you look, for example, if you look here at the lung parameters, you see all significant were correlated with the pattern, the late pattern, or significant correlation you observe in the progression of the pattern. What's about the treatment on the morphology of capillaroscopy? Well, if you combine the endothelin-1 receptor inhibitors that reduce the progression of fibrosis and the prostacyclin, that is dilator, iloprost, you can see that there is a very significant improvement after 1 year of the capillary number. You see, when you associate. So, in other words, you can reverse the loss of capillary by improving sorry, the microcirculation and reducing the suffering of the tissue. And if you look with the LASCA, laser specklet analysis, the severity of Raynaud at the baseline in this patient, and over the year, over 3 years, after the treatment, you see that together with the increase of the number of capillaries that I mentioned, you see also a light improvement of the vascularization and the blood flow. You see the green, yellow mist better than blue. Blue is hypoxia. So the treatment, the combination treatment, induce improvement, and with capillaroscopy, we can see that. If we want to conclude here, because the time is going, the capillaroscopy offer for sure a very easy system. And in the last 20 years, as you can see, now we can with proudness say that capillaroscopy is included in classification criteria by the two major rheumatologist association. And during the Euler courses we started in 2004 in Genoa, you see the increase of the countries participant. Many rheumatologists from Egypt came. I think also someone of you came, and we had this large participation. So unfortunately, you can see this course cannot be done because of COVID. Will be done next year, so people interested can subscribe. And I can conclude that capillaroscopy today it's again very safe, pocketable. You can put in your pocket a small capillaroscope, and then you can record the picture when you connect it to the PC and evaluate the data. And so you give to yourself, to the doctor, to the patient, by the scoring of the lesion, the number of capillary, also a number. We need a number to evaluate the effects of therapy and to predict the evolution of the disease. So in conclusion, we can say really that in the last 20 years, we had a very important progression at the level of the disease. Thank you.
Thank you, Professor Tutulu. You can stop sharing. Yes, dear Professor. Thank you so much for this nice, very deep scientific yet simple lecture connecting the pathophysiology with the clinical manifestations of Raynaud's phenomena and peripheral vasculature insufficiency. Let me sum up or summarize what some of the important points that you have said, that capillary microscopy is a simple, a little bit cheap and accurate tool that gives us an eye on what's happening in microcirculature. It has a diagnostic and prognostic value as well. Let me ask you that or emphasize the point that the algorithm you have mentioned to us is used to differentiate between scleroderma and non-scleroderma pattern, right? After this, we will have real-life cases presented by our coordinators. I would urge our participants, if you have any questions, it will be answered at the end of the workshop by Professor Kutulu. Please write your question and answers in the Q&A box. And now, first case will be presented by Professor Mary Wadia, Assistant Professor of Internal Medicine and Rheumatology, Cairo University. And please, Professor Mary, the floor is yours.
دكتور سماح مع حضرتك. الصوت مش واصل يا دكتورة سماح.
هنتفضل نبتدي البرزنتيشن يا دكتورة ميري. دلوقتي تبدأي، اتفضلي. دكتور أشرف.
Stop sharing.
دكتور أشرف, stop sharing your screen علشان تقدر دكتورة ميري to share her screen, please.
Mary, please share.
Good evening. I'm very happy to be with you. I am Mary Wadia, Assistant Professor of Internal Medicine and Rheumatology and Immunology, Cairo University. I'm very happy to be with you in this large conference. I'm very thankful for the organizing committee. Let us start our case. A male patient, 30 years old, presents with proximal muscle weakness, dysphagia, dysphonia, and Raynaud's phenomena of 6 months duration, with no history of skin rash, oral ulcer, arthritis, and no history suggestive of other system affections. Investigation of our patient revealed normal CBC and kidney function, elevated CBK and AST, elevated acute phase reactant in the form of elevated EGYSIR 100, CRP 40 mg per deciliter, ANA by immunofluorescence was 1/80 speckled, anti-DNA and anti-Jo1 were negative. Unfortunately, we have no serum aldolase as it's not present in our labs. EMG revealed myopathic feature. So what is the differential diagnosis of our patient? We suggest that our patient may have an autoimmune myositis second to collagen vascular disease, where he had dermatomyositis sin dermatitis as he had no skin lesion, or that the patient has an internal malignancy or paramalignant myositis. So suggest to do capillaroscopy in order to differentiate as he has an autoimmune capillaritis in capillaroscopy or not. Our capillaroscopy revealed ramified capillaries as we see in this picture, loss of capillary density, also a new vascularization and ramified capillaries. Also, we have a scleroderma-like picture. We have large capillaries and the extravasation of the capillaries. We have capillary hemorrhage in the capillary. This picture is more clear. So the differential diagnosis of our patient was limited that we have an autoimmune myositis and the presence of ramified capillaries and scleroderma-like picture in capillaroscopy suggests that we have a dermatomyositis and dermatitis, which is very rare condition, but our patient has no skin lesion. Either he will continue like that or he will develop skin lesion later on. We don't know. We'll follow up our patient. But when we diagnose dermatomyositis, we are very afraid of internal malignancy, so we do abdominal ultrasound and CT chest, and tumor marker and all were normal, but we're still very anxious about internal malignancy as he is male and 50 years old. So we do a PET scan and it was normal, and we was happy with this result as our patient has no criteria of internal malignancy. Also, I want to notify you that capillaroscopy is an aiding tool for the diagnosis of dermatomyositis, but we don't have a fixed criteria for the diagnosis of dermatomyositis in capillaroscopy. And thank you. Good evening. I'm very happy to be with you. I am Mary Wadia, Assistant Professor of Internal Medicine and Rheumatology and Immunology. I'm very happy to be with you in this large conference. I'm very...
Professor Kutulu, what's your comment on this case with dermatomyositis clinical presentation and her capillary microscopy pictures?
Exists the so-called, as mentioned, in the scleroderma-like pattern. And so if the diagnosis was for dermatomyositis, it's absolutely possible to look at this pattern that usually is much more complex, not so, can I say, dissociated giant from angiogenesis. You get all together the different lesions I showed to you in the different pattern, active and late. So you mix in dermatomyositis scleroderma pattern, even angiogenesis, much more than in the active scleroderma pattern. But in any case, the scleroderma-like pattern, as you call, in dermatomyositis is possible. I don't remember if they found specific anti-Jo1 antibodies. I don't remember because the slide was very fast. But
no, we don't have, sorry for interruption, but we don't have anti-Jo1 was negative. Only from the autoimmune profile, ANA was positive, 1/80 pickle, but other autoimmune profile was negative.
So extractable nuclear antigens were negative. INA antibodies, not ANA, INA.
Yes, INA, yes, NA antibodies was negative.
Okay. So usually are positive associated, but maybe in this case was treated with steroid at the time of the evaluation of the blood findings. The patient was under glucocorticoids.
No, for first diagnosis, he was not under corticosteroid, okay. But we start glucocorticoids after diagnosis.
And what happened? Do you have a follow-up regarding at least the concentration antibodies, if I remember, was very low, 180.
Yes, follow-up, CK total become declined, AST returns to normal level, and patient activity returns to full power and full activity with good muscle power. But we do not repeat capillaroscopy after treatment.
Okay. Would be nice to do this, if possible, still or now.
Yes, it would be very nice to repeat capillaroscopy. I decided now to repeat it.
Thank you.
Okay.
Thank you.
Thank you so much, Professor Mary. Our second case will be presented by Dr. Ahmed Fahmi, lecturer of rheumatology and rehabilitation at Al-Azhar University. The floor is yours, Dr. Ahmed. تفضل.
يعني انت مش عايزه تقول اصلا
sharing screen please.
طب يا سلام ربنا يخليك.
Hello everybody, I'm Dr. Ahmed Fahmi, lecturer of rheumatology and rehabilitation at Al-Azhar University. I'm so happy to be with you today in this virtual workshop concerning capillaroscopy. At first, I'd like to thank EGYSIR committee for inviting me to this interesting workshop. Also, I'd like to welcoming Professor Cotolo for being with us in this conference and workshop. Rapidly, I will start my lecture about capillaroscope under title of Don't Rush. When we face a case of Raynaud's, we should ask ourselves few questions. Is it primary, secondary? Is it acute or chronic? What about laboratory finding? What about capillaroscope? Is there any changes? Yes or no? And if there's changes, is it specific for certain disease or not? What is the associated sign and symptoms? And you should ask yourself, what is your final diagnosis and what's your management plan? So I have two different cases concerning capillaroscopic finding and how it could mislead you to diagnose some diseases like scleroderma wrongly or to rush to this diagnosis without to be certain. So I have two cases I'd like to discuss with you. The first one, male patient, one of our colleagues, doctor, 33 years old, heavy smoker, presented with Raynaud's phenomena a few months ago. He sought medical advice, one of our greatest professor, and this professor asked to capillaroscopy and anti-nuclear antibody titration pattern and other lab. we see this patient to do capillaroscopy for him even before lab test, not to be biased with and this is what we found rapidly. There is almost normal capillaroscopic finding apart from this capillary and this capillary. So we have 1 and 2, 3 changes called branching in capillaries. However, other capillaries, it seems normal. But we found also some hemosiderin patches or some staining. So this is a finding, hemosiderin and some tertious capillaries. So this is the rest of his examination. Most of fingers within normal, capillaries U-shape, refilling is dynamically is very good, but there is some haziness on the margin of the capillaries. This is another photo. The hemosiderin patches, most of capillaries is okay, some haziness. So when we face a case like this, again we should ask ourselves same questions: primary or secondary. This case mostly is primary. What about lab? The lab later on become when we recruit the laboratory finding, this was so normal, no abnormality in the lab. Capillaroscopic changes not specific. Associated signs and symptoms, no, nothing to be mentioned. Our final, this case is not scleroderma. However, follow-up is recommended. So never to be rush in case like this. This is a finding regarding capillaroscopic. This patient is a smoker, and smoking is one of leading causes of changes in capillaroscopic findings. So don't rush. This is not a case of scleroderma, even if there is Raynaud's. This Raynaud's phenomena, not pathological, no pathognomonic changes in the capillaroscopic change. So this case is not scleroderma. However, you should follow up. Follow up is recommended after 1 or 2 years with capillaroscopic, as 10% of Raynaud's phenomena or primary Raynaud's become secondary 10% 1 or 2 years later. So this is our first case. Change to the second case. Female patient, 50 years old, housemaid, married with no sibling and no special habits of medical importance, presented with history of whitish discoloration of all fingers, especially when used cold water during her work, associated with mild pain a few years ago. Again, this patient is housemaid. She do everything with water and cleaning. She is housemaid. She sought medical advice many times, no conclusive diagnosis. 5 months ago, she went to a rheumatologist and capillaroscopic was done and diagnosed as early scleroderma according to report. We follow up this patient and redo capillaroscopic after about 5 months to see what's going. This is old report, nothing significant apart from there is giant capillaries, okay, and some capillary hemorrhage. Giant capillaries alone is one of the manifestation of early scleroderma, but it should be interpreted according to all circumstances. Within the circumstances, she is housemaid and everything she doing by her hand. Okay, no clinical data, no lab. When we face here, we check again for laboratory test. All lab was within normal range, apart from positive rheumatoid factor. When we check the capilloscopic finding, we see hemorrhagic or hemocytic capilloscopic capillaries numbers within normal, filling dynamically within normal. There's some haziness and no no sign of any changes, no change in capillary size or shape, no capillary loss, nothing apart from hemorrhage. Again, capillary filling is normal, shape is normal, everything is normal, no capillary loss. So we ask ourselves again, what about all this question? The answer is this case is again not a scleroderma. However, follow-up is recommended. But what about the old report about giant capillaries? If we face a case of scleroderma and do follow-up, there is no regressive course in scleroderma. So once we see a giant capillaries, it's supposed, if it's a true scleroderma, it's supposed to be a more progressive course, and more and more changes become, or at least giant capillaries not disappear. But in this case, we have no abnormalities apart from hemosiderin patches, which could be due to trauma, multiple trauma, or recurrent trauma. So again, this case not considered as a scleroderma. However, follow-up is required. So our finally take-home message: don't rush, as capilloscopy may show a wide range of findings, most of them non-specific for certain disease. So don't rush. Thank you so much. I'm sorry for being taking time. Thank you and goodbye.
Thank you, Dr. Ahmed. Sometimes we really face those cases. What's your comment, dear Professor? Professor Kutulu, what's your comment on those cases? If we have if the operator that have done the first the capillary microscopy in the second case had followed the algorithm you have just shown us to differentiate between scleroderma and non-scleroderma pattern, would have been this helpful?
The first case, I totally agree. The conclusion and also in suggestions, don't rush. The second case, here should be much more clear what we mean for giant. Giant is a dilation, as I show, like horse shape. So dilation over 50 might be homogeneous along all the arch of the capillary. So a dilation over 50 micrometers or 0.056, like in the picture, millimeters, that means micrometers 56, is absolutely not a giant, what I saw. If I well understood, was classified by giant. Giant should be dilation homogeneous in all the structure of the capillaries. So this probably was a pre-giant, and I agree that the follow-up is fundamental because, as mentioned, even in primary Raynaud, even with some non-specific abnormality like dilation, 60% in our last study will develop a secondary Raynaud phenomenon in from 6 to 12 months. So the probability that capilloscopic pattern observed without specific abnormality, specific of systemic sclerosis, are evident, so non-specific abnormality, it's important the follow-up, because in presence of other risk factors, and maybe the use of estrogens in young girls that enhance the immune response, for example, or maybe concomitant infection that accelerate the immune response, or maybe a toxic substance that may alterate the endothelium, and all together, as well as stress, chronic stress, and reduction of endogenous glucocorticoids, may enhance this initial damage, increase the immune response, and change even the morphology in a real giant, and so associated with secondary and associated with Raynaud dermatomyositis, maybe also other antisynthetase. We saw the antisynthetase syndrome, some of these aspects. We are working on it, really something is published, or in mixed connective disease, or an unclassified connective tissue disease. So both cases suggest the follow-up, and totally agree. In presence of Raynaud, and presence of even abnormal specificity after 6 months, depend from the severity. 6 or 12 months, it's correct to evaluate again this safe and non-invasive morphological examination like capillaroscopy, in order to predict, anticipate the clinical signal of the eventual associated disease. Thank you.
So you suggest it's better to follow up the case every 6 months. Would you advise her to avoid exposure to cold, or dumping her hands for several hours in water? Will any treatment as preliminary vasodilator help in this condition?
Exactly. If there is the Raynaud phenomenon that is increasing over the year, that is present also outside the coldest season of the year, winter, so it's in any case correct a preventive vasodilator therapies at the beginning of fall. So giving some vasodilator, maybe oral vasodilator at the beginning, or we do when the Raynaud become more serious and we get maybe some little skin damage, the iloprost, the prostacyclin and the venous, 5 days, 5 hours a day for 5 days, and this makes very, very sustained dilation. Of course, if you observe at the same time the presence of antibodies, significant antibodies, anti-nuclear antibodies, or even more extractable nuclear antibody, specific antibody, at that time it's correct to start immunosuppressive therapy. At the beginning, maybe oral immunosuppression, and then we found some reversal of the disease with the anti-CD20 therapy with rituximab, once every 3 months, 4 months, depends from the severity. But the combination therapy with vasodilation, with immunosuppression, and eventually antifibrotic therapy like bosentan may reduce, anti-endothelin 1 or 2 receptor therapy may really improve the prognosis and stop from the beginning. You should intervene as soon as possible when the diagnosis is done. But at the level of the patient shown before is just the suspicion. So the follow-up is important, and we already discussed why.
Yeah, thank you. The last case will be presented by Dr. Sharif Ismail. Dr. Sharif is an MD doctor for rehabilitation and rheumatology at Research Center. Kindly stop sharing, Dr. Ashraf, for Dr. Sharif to share his slides, please. Dr. Sharif, the floor is yours. You can start.
Thank you. Thank you.
I would like to start by thanking the EGYSIR Society for this fruitful and valuable virtual scientific meeting. So start with our systemic sclerosis case. We had a female, 37 years old, worsening Raynaud's phenomenon over 1.5 years, progressive, no skin thickening. She had mild arthralgias in small joints of the hands and some finger swelling, myalgias and fatigue, some knee osteoarthritis, well-controlled hypothyroidism, some mild hypertension, and some long-standing GIT manifestations. So nothing much specific for systemic sclerosis here. Her labs, she had an ANA positive, anti-scleroderma 70 autoantibodies were positive. The rest of her labs and the chest X-ray were more or less unremarkable. We performed nail fold capillaroscopy twice, 7 months apart, and the second assessment, the musculoskeletal manifestations had worsened. Quick look at the normal before we see our capillaroscopy pictures. We could see the homogeneous, uniform, well-defined hairpin shaped capillaries of the distal row, no loss of capillary density, no abnormal shapes, no hemorrhages. This is a picture from her first assessment. Not much abnormal shapes here, but you could identify the microhemorrhages that are distal to the distal row of the capillaries, these characteristic reddish brown spots. Some mild microhemorrhages can be here, and this is also a picture from the first assessment. We have an enlarged capillary here, 90 micrometers in width. Not necessarily a giant capillary, but definitely a well-enlarged mega capillary visible here. And here we have a picture from the second assessment 7 months later. The pathology here clearly got worse. This could correspond perhaps to an active pattern, active scleroderma pattern. You can see the abnormal shapes here, the twistings and the tortuosities, the coiled capillaries. We could see the crossings. We have some capillaries with the afferent and the efferent loops totally crossing over each other, and disorganized shapes. And you can see this clear, huge microhemorrhages down at the bottom of the picture. Another picture from the second assessment, also corresponding more to the active pattern. We had perhaps some of the early scleroderma pattern visible maybe in the first assessment. Here we have more of the active scleroderma pattern. You could see here these very weakened capillary walls. It's very hard to identify the capillaries. The walls have become so thin and so weak due to the vasculopathy, due to the pathology that's going on in these vessel walls, and you have very weak blood flow flowing through this region. If we had the video recording here, you would have seen the RBCs moving. You would have seen the sluggish blood flow, the RBCs struggling to get through these irregular vasculitic weak capillary walls. So this is definitely showing some pathological signs. And here we have another picture from the second assessment showing the loss of capillary density. We need more than 9 or more capillaries per 1 millimeter. Here, this is a zoomed picture. This is 1 millimeter, and we have only 3 capillaries that we could count. This one in the middle is just one single branched capillary. So we have only 3 capillaries here, which is definite huge loss of capillary density. And we definitely do have a scleroderma pattern. If we use also the fast track algorithm here, we did have 3 or less capillaries in 1 millimeter. So we definitely do have a scleroderma pattern. We have seen the pathologies, we have seen the microhemorrhages, we have seen the abnormal shapes, we have seen the enlargements, and we have seen the loss of capillary density. So when we also talk about differentiating primary from secondary Raynaud's, these pictures definitely do show that we have secondary Raynaud's phenomenon. To achieve the diagnosis of systemic sclerosis, we still have to complete the other criteria and do some clinical lab correlations. But here we definitely do have a very definite secondary Raynaud's phenomenon. We have to say that to differentiate primary from secondary Raynaud's, we usually rely on the capillaroscopy findings and the ANA, which are also, of course, the important factors for the VDOS criteria or algorithm, which is the very early detection of systemic sclerosis. But we have to say here that the capillaroscopy now is even more significant than the ANA, because the changes in the capillaroscopy could appear before the autoantibodies become positive. And thank you all so much.
Thank you, Dr. Sharif, and definitely, Professor, I think you have recognized Dr. Sharif. He was one of your trainees in one of the ULAR courses for capillary microscopy, and we will appreciate your comment on this case as well.
Two courses, not one, 2.
2 courses. You are muted, dear Professor. Please unmute yourself.
Sorry.
Yeah.
Someone muted me. Someone muted me.
No.
I say gold medal for 2 courses means gold medal. Well, here I can say that you showed some images. The only thing I can say is that if you look at the crossing of the capillaries, this should be not considered specific because the crossing, the overlap, okay? This is usually a non-specific abnormality. Can be associated with the pattern, of course, but you can see also in normal pattern these overlaps. Again, you supported the concept and the reality that low number of capillaries is the most important aspect. So the parameters we can use when we decide to score and to give a prognosis and to look at in the qualitative pattern, for example, inside the qualitative pattern active, the severity is the number of capillaries. And over time, when you do the follow-up, the number of capillaries may decrease a lot because the disease is going fast or slowly. And so still the number of capillaries, even if you have a transition from the qualitative pattern, the morphology, to the quantitative expression of the damage, the number of capillaries, the number of capillaries, and you mentioned it many times, still important. The real parameters over 1 linear millimeter with a magnification 200. So I think that your presentation was quite clear, well done. So I have no comments.
Thank you, Professor. I would like to express our deepest appreciation, not as EGYSIR members and attendees, but also we have attendees from several Arab countries like Saudi Arabia and Jordan. They are expressing their appreciation for the quality knowledge we are presenting at this workshop. And for the sake of time, we have a few questions. I would like to ask you, to be accurate, our attendees sent those questions. You said that capillary microscopy can predict organ damage or end organ damage in systemic sclerosis. So do you suggest to follow up patients with capillary microscopy to see the progress or the improvement in the capillaries by treatment? And if so, what are the intervals? Every 3 months, every 6 months to follow up the patients? What do you suggest?
As I mentioned, when you have an active, clear overt disease, systemic sclerosis, for example, every 6 months is what we do and we suggest, because we saw that you have fast patient and late patients to develop the further damage. So it's important to look at least every 6 months and count the number of capillaries. Thank you for the question.
Do you see that there is reversal of the damage by follow-up and successful treatment? The number of vessels will increase. This
Absolutely.
is a sign of successful treatment.
Absolutely. I showed just one slide, one representative study combining iloprost with bosentan, the improvement, but don't rush. Wait at least between 6 and 12 months before to see significant regression. This is, systemic sclerosis is a very slow disease, progressive disease. You cannot see morphological changes in a short time, months, weeks, or months. But we have a lot of paper. I didn't present all the paper, a lot of study from different groups showing that the treatment, when successful, increase and revert the qualitatively observation and the quantitative observation. So the number of capillaries increase because there is less destruction, less immune response, and so revascularization become active.
Okay. How often do the scleroderma pattern apply to SLE pattern?
To SLE?
SLE, yes, systemic lupus. How often do the scleroderma pattern is applied to SLE?
Yes, no, this scleroderma is not evident in lupus, such kind of damage. The damage we observe in lupus, we produced a systematic review. It's quite different. The elongation of capillaries, you may have some hemorrhages, but never giant or other aspects where we presented in systemic sclerosis, even because disease do not evolve in fibrosis. Systemic lupus is much more an inflammatory immune-mediated disease, inflammatory. And the endothelium, the microvessel are not the major targets, are one of the targets, but in the systemic lupus, we have, as you know, 100 or antibodies against any kind of cells and antigens. So you have also some capillaroscopic change, and in particular, patients with lupus that get coagulopathy, you can observe microthrombi, like in antiphospholipid syndrome. And so in case the patient are characterized by abortion or thrombosis or any phenomena related to coagulation, here capillaroscopy is very useful because can detect in presence of a cardiolipin antibody IgM and IgG the presence of microthrombosis.
So, Professor, you have suggested to follow up patients with capillary microscopy every 6 months to see any difference and progression or improvement according to treatment. So, how long should be immunosuppressive therapy taken after we have a satisfactory, let me say, revascularization? First of all, let me ask, do the vascularization of nail fold capillaries return to normal or they just improve?
They just improve, depends from which pattern you start. If you start from late or very advanced, even the immune suppression is not so effective. That is why I said the late is a disaster, because the disease is so advanced that the fibrosis make it difficult to revascularize in a normal way. But in any case, if you are between early active and late, and you use a good immunosuppression, you can do this up to the reduction of CD20, CD19 to zero reverted. When you see the title of antibodies, the concentration going down, and you look at the clinical condition, functional test for lung function, for example, and improving, you can reduce the intensity of the immunosuppression, of course, in order to avoid secondary problems like rise of cancer, infection, and so on. But you have to stay very careful if restart the population of B cells, restart the antibodies production. And we produced recently a paper showing the result in systemic sclerosis treated with rituximab and looking at the antibodies, the capillaroscopy, and we got very interesting result. But in particular, the immune suppression in advanced cases stop the production of antibodies and stop the decrease of capillaries. So reduce or stop the progression of desertification.
Okay. Dear Professor, you have mentioned that capillary microscopy could be correlated with the degree of pulmonary artery hypertension. Would you suggest that this simple, non-invasive technique, capillary microscopy, could replace the right heart cath that we definitely need to do to diagnose primary or vascular pulmonary artery hypertension? As you know, treatment will be different if I have secondary pulmonary artery hypertension or primary pulmonary artery hypertension. So what's your opinion?
This is a very important point. In fact, again, with systemic review published, we went to see how many signalation there are concerning the capillaroscopic changes, the pulmonary hypertension patient, and the treatment. And here you cannot totally substitute, of course, there is no evidence, but you can add the capillaroscopy to the evaluation of the pulmonary function, because there is a significant correlation with the number of capillaries. So again, the intensity of the capillary loss that you observe in the microcirculation of the nail fold reflect also the reduction of the capillaries in the lung structure that you know is associated, and the fibrotic process, that means advanced fibrosis, and is correlated with the values of the pressure, the arterial pulmonary pressure. So the capillaroscopy, now we have just finished a study in treating the interstitial lung disease in systemic sclerosis with a new drug, antifibrotic drug that is also on the market, nintedanib, and we saw that capillaries improve, the number of capillaries. The data are under analysis. So the suggestion to use capillaroscopy as an additive test, very safe and cheap, because once you have the capillaroscope, you don't spend one more dinar. and so you have a very good and easy. Of course, you need a large study, and at the present there aren't.
Okay. Last question. Would you manage a case of secondary Raynaud's phenomena though all immune panel is negative? A secondary Raynaud's phenomena.
Sorry, I can hear.
Would you manage a secondary Raynaud's phenomena though the immune panel, all the antibodies are negative? So we have by capillary microscopy secondary Raynaud's changes, but the lab is negative. Would you manage such case?
Well, here we must consider what we mean with negative, because 20 years ago we considered only 2-3 different antibodies. Today we are able to see very sophisticated antibodies, anti-endothelial cells, anti-polymerase, so before to say negative, we should test, but this is not possible in all labs, all the possible associated specific antibodies to look if someone of this is present. There are some cases, or anti-CCP in rheumatoid arthritis, for example, that appear even 15 years before start the rheumatoid arthritis. So, but you have to test this. So, for example, anti-endothelial antibodies have been found associated with the capillaroscopic changes. And sometimes the concentration antibody is not so large to be detected with the common laboratory test. So if you have a real autoimmune disease is not in remission, usually you should have some antibodies. Maybe the concentration is very low. Maybe you didn't test the right antibody or didn't find. But to say categorically that patient with Raynaud and autoimmune disease with clinical symptoms, and Raynaud and positive capillaries are totally negative is hard to say at present.
Yes. And the last clinical tip, what are contraindications for capillary microscopy? For example, can we do capillary microscopy for dark-skinned people? Can we do capillary microscopy for manual workers? Can we do capillary microscopy in females doing pedicure in their nails? Is there a precaution list for the patient taking an appointment for capillary microscopy? Do this and don't do this before the examination to get the best result?
I agree. There are some confounding factors. Even the job of the operator may induce some changes. They are not pathological. Or gardening. There are a lot of patients, they do gardening, and then they come and we see microhemorrhages. But you discover this because it's localized, it's not associated with the loss of capillaries, for example. But in some cases, it's hard to distinguish because maybe coincident with Raynaud, and you think that this lesion in a lady, as you say, that they neck up or something like, is associated with hemorrhages, as it's not. So I suggest, like you say, that capillaroscopy has some guideline to consider. At least the operator ask to the patient if found some strange changes, but no giant. Giant is impossible with any other artifact. Is not an artifact, giant, the real giant. Ask to the patient, have you done yesterday or the last week something with the finger, and so on. And this is important. I agree with you.
taking history. We are privileged by the attendance of Professor Ali Youssef, the chairman of the Congress. He has been with us since a while, and we didn't want to interrupt. Hello, Professor Ali Youssef. If you want to welcome Professor Kotlu before we finish. Will you unmute yourself, Professor Ali, please?
Okay.
Yeah.
Thank you very much, Professor Kotlu, for this very nice and deep presentation. But I have some about the first case of Dr. Mary. Do you think that it was essential to detect?
دكتور علي الصوت واطي شوية دكتور علي بعد إذنك. Please raise the voice.
I can hear.
كده كويس؟
لا لسه
كويس. طيب الو سامعني يا سامعني يا دكاتره؟
علي الصوت شويه يا دكتور علي.
انا معليه خالص، دلوقتي. طيب بص يا دكتور بروفيسور كوتلو، is it do you think that the case of Dr. Mary, it was important to detect anti-scleromyositis antibodies in this case, since there is confusion between is it myositis and the capillary microscopy give the picture of scleroderma. Do you think that we have to detect these antibodies since there is a mixture between myositis and scleromyositis? And thank you very much.
Which antibody, Dr. Ali? Say it again.
Scleromyositis antibody.
He was asking in the first case, the case of dermatomyositis, would it have been helpful to ask for anti-scleromyositis antibodies?
Yes, I agree. It's the same my suspicion to do. As I mentioned, when you have such form of autoimmune connective tissue disease, and you have a clinical symptom suggestive, to check to the marker, immunological marker in the serum, like antibodies in this case specific, before to test the diagnosis or delete the diagnosis, the possibility. I agree totally with you. Thank you.
Thank you very much. Thank you very much.
Thank you. Thank you, Professor Kotlu. By now, we end our workshop. We still have a very interesting, very practical lecture by Professor Kotlu, live as well, Saturday evening, right, Professor? Waiting for you then. I hope everybody have been satisfied. I hope this workshop have added some lights on the indications, contraindications, the usefulness of the capillary microscopy in the diagnosis of connective tissue disease, and as well as follow-up in patients with scleroderma, as it can help in predicting end organ damage and progression, and it as well can be used to monitor therapy for those patients. Thank you all attendees for being with us for more than 90 minutes. Thank you, Professor Kotlu, for sparing more than 90 minutes from your precious time, waiting for you on Saturday evening for a more scientific lecture. Thank you all, and we will have to rest before restarting our scientific program. Thank you and goodbye.
Thank you to all of you and goodbye. Thank you.
Thank you.
Thank you very much.
Bye-bye. Thank you. Bye-bye.